Juvenile nasopharyngeal angiofibroma. It's a benign, locally invasive vascular tumor usually seen in adolescent males. Etiology. Exact etiology is not known. It is thought to be testosterone dependent. Site of origin. Usually arise from the superior margin of sphenopalatine foramen, or it can arise from the pterygopalatine fossa. The tumor may extend and fill the entire nasal cavity, paranasal sinuses, orbit, pterygopalatine fossa, infratemporal fossa, or it can extend to the cranial cavity. There is a staging system called FISH staging for juvenile nasopharyngeal angiofibroma. Stage 1, the tumor is limited to the nasal cavity without bony destruction. Stage 2, the tumor extends to the pterygopalatine fossa and maxillary, sphenoid or ethmoid sinus with bony destruction. Stage 3, there is invasion of the tumor to the infratemporal fossa and orbit. Stage 3A is without intracranial extension, and stage 3B is with intracranial, paracellular or extradural involvement. Stage 4, there is intracranial and intradural extension. Stage 4A is without involving the cavernous sinus, pituitary fossa or optic chiasma, and stage 4B is with involvement of the structures. Clinical features. Age group affected are adolescent males. There will be profuse paroxysmal painless epistaxis, progressive nasal obstruction, headache, anosmia, mouth breathing, snoring, and obstructive sleep apnea. Otitis media with effusion and conductive hearing loss. Depending upon the extent of growth, there may be proptosis, swelling of cheek, or cranial nerve palsies. If there is profuse paroxysmal painless epistaxis in an adolescent male, should doubt juvenile nasopharyngeal angiofibroma. Gross appearance. Pinkish, lobulated, firm mass in the choana. It may be sessile or pedungulated. Histology. Thin-walled vascular channels with fibrous stroma. Vessels have single endothelium-lined walls without muscles or elastic tissue. That's the reason for severe bleeding. You should not palpate the tumor or take biopsy unless under anesthesia in an operation theater because of the chance of bleeding. Investigations. CT scan with contrast to know the extent of the growth and bony destruction. Holman-Miller sign or Andrel sign. It is anterior bowing of the posterior wall of maxillary antrum in CT scan. It is diagnostic of juvenile nasopharyngeal angiofibroma. MRI to assess the extension of growth to the soft tissues, orbit, and cranial cavity. Digital subtraction angiography is taken to know the feeding vessels, and you can do diagnostic nasal endoscopy. Differential diagnoses are antrochoanal polyp, angiomatous polyp, rhinosporidiosis, carcinoma of nasopharynx. Treatment. Surgery is the treatment of choice. Preoperative angiography to identify the feeding vessel and embolization to reduce the intraoperative bleeding. Endoscopic removal or transpalatal approach is used for tumors limited to the nasal cavity or nasopharynx. Lateral rhinotomy and medial maxillectomy or Sardanus approach, that is sublabial approach. It is used for extension of the tumor to maxillary sinus or pterygopalatine fossa. Midfacial degloving approach and Lefort 1 osteotomy is used for tumors with lateral extension. Intracranial extension needs craniotomy along with any one of the extracranial approach or radiation therapy if the tumor is inaccessible. The role of radiotherapy is controversial. Usual dose is 30 to 35 gray. It is used for recurrent tumors, tumors with intracranial extension, tumors with feeding vessels from internal carotid artery. Hormonal therapy with a diethyl stilbestrol and flutamide is used to arrest the growth of the tumor. Chemotherapy with doxorubicin, vincristine, and dacarbazine is used for residual and recurrent tumors. Thank you.